Okay. Good evening, everybody. Shall we start our program?
ಗೊತ್ತಿಲ್ಲ. ಗೊತ್ತಿಲ್ಲ ಕಣ, ಅವನು ಎಲ್ಲಿ ಹೋಗಿದ್ನಂತ.
Hello. Okay, am I audible to you all? Hello?
Yes, sir.
And
Sir.
the slides, can you see the slides?
Yes, sir. Yes.
Okay.
Yes.
So good evening to all. Today we will start with hemodynamics. What is meant by hemodynamics? Anybody would like to answer that? Hemodynamics means, hemo means blood. Everybody knows. Dynamics is that branch of physics which deals with movement of objects. So when you put these two terms together, hemodynamics, it means movement of the blood. It deals with movement of blood. So in movement of blood, we should know, one, how much blood is moving, cardiac output, left-right shunt, right-left shunt, regurgitant lesions, regurgitant fraction. We must also know what is the pressure which is driving the blood. That is the pressure generated in various cardiac chambers. And the driving pressure is obtained from the contraction of the left ventricle on the systemic side, and that was the right ventricle on the pulmonary side. So it deals with two aspects. One, the pressures and the flows. First, I will give you some introduction about the hemodynamic, the basics of hemodynamics, and then we will go ahead with the analysis of a good few data, so that you are clear how to look at the hemodynamic data. Then, as I told you, the hemodynamics deals with how and how much blood is flowing, and two, the pressure which drives the flow. There are certain principles of hemodynamics you should know. Blood flows from an area of higher pressure to an area of lower pressure. That should be very clear to you. Blood cannot flow, just like any other fluid, from an area of lower pressure to an area of higher pressure. Let us take an example. Let us say, let's look at a person whose left ventricular and diastolic pressure is, let us say, 5 or 6 millimeters or 7 millimeters. And correspondingly, left atrial pressure may be 7 or at the most 8. So the blood can flow from the left atrium to the left ventricle when the mitral valve is open. Due to some disease process, if the LV and diastolic pressure goes up, to 10 to 12 or 13 or 14, 15, then if the blood is to flow from the left atrium to the left ventricle, correspondingly left atrial pressure should go up. That's the most important thing you should know. That whenever there is an increase in the downstream pressure, the upstream pressure also should correspondingly go up. So if the LV pressure goes up during diastole, the pressure in the left atrium also should go up during diastole. Then only the blood can flow from left atrium to the left ventricle. It applies to all upstream positions. When a downstream pressure goes up, upstream pressure correspondingly should go up. So if the left atrial pressure goes up, then the pulmonary venous pressure should go up, pulmonary artery pressure should go up. All these things should happen, and that is the basis of developing pulmonary edema and other symptoms when there is a pressure elevation in the left ventricle and left atrium. Next point is when cardiac valves are fully opened, there will not be any significant pressure gradient across the valve. Unlikely to have any pressure gradient when the valves are open. There can be minor gradients, for example, the gradient which is allowed across the tricuspid valve. Anybody knows what is the standard upper limit of the normal pressure gradient across the tricuspid valve?
Less than 2 mm.
Yes, 1 millimeter. 1 millimeter, 2 or above is abnormal. Less than 2 can be taken as correct, but 1 millimeter is more correct. 1 millimeter, 2 or above is abnormal. On the mitral valve,
3 millimeters.
Less than 5.
up to 2. 2 millimeters is fine. Above 2 is abnormal actually. If it is 3 or more, you have to take it as abnormal. Across the pulmonary valve, across the pulmonary valve, what is the peak pressure gradient? You can calculate it from what is the normal the Doppler velocity across the pulmonary valve.
4.
Four,
Around
huh?
1.
4.
The velocity is 1, sir. So the pressure is around 4.
Oh, very good. 4. 4 millimeters, up to 4 millimeters of mercury can be taken as abnormal. As usually say 4 to 5. And across the aortic valve,
So same again 4 to 5, sir.
no. Aortic valve can be, because the velocity can be upper limit is up to 1.5 to 1.7. So the 4v squared will be 1.5, that is about 10 or 12. Up to 10 or 12 can be taken as can be accepted as the upper limit of normal. So the across the tricuspid valve 1, across the mitral valve 2, across the pulmonary valve 4 to 5, and across the aortic valve 10. 10 would be accepted as normal. Then when the valves are open, fully open, there will not be any significant pressure gradient across the valve. When a valve becomes stenotic, there will be pressure gradient across the valve. That is how we recognize that the valve is stenotic. The pressure gradient across a valve is proportional to the degree of stenosis, provided the flow remains the same. For the same amount of flow, the pressure gradient is proportional to the severity of the stenosis. Gradient across a stenosed valve will be decided also by flow across the valve. If a valve is stenosed and if the flow comes down, the gradient comes down. In the same valve, same degree of stenosis, if the flow becomes more, then there will be higher gradient. Higher the flow, higher the gradient. Equalization of pressure across any communication can occur only if the opening is non-obstructive. For example, in a patient with ASD, if the pressure in the right atrium and the left atrium are identical, that obviously means that it is a non-obstructed ASD. If there is a gradient, obviously means that it is not freely flowing. There is an obstruction for the flow from left atrium to right atrium or right atrium to left atrium, depending upon the pressure in these two chambers. So equalization of pressure across any communication can occur only if the opening is non-obstructive. Fixed principle is used to calculate the cardiac output. All of you know fixed principle. The fixed principle cardiac output is calculated from the formula. Cardiac output in liters per minute is equal to oxygen consumption per minute divided by artery venous oxygen difference per liter. So this is the formula that we apply to calculate the cardiac output. Cardiac output in liters per minute is equal to oxygen consumption per minute divided by arterial oxygen difference per liter. What is the standard oxygen consumption per minute? Any one of you? What is the standard oxygen consumption per minute?
125 into body
120
surface
to
area
125
into body surface area.
ml per meter square.
Little more correct. Can you say little more precise? Per kilogram body weight?
3.4 ml.
3.5. 3.5 ml per kilogram body weight. So for a 70 kilogram man, the oxygen consumption per minute is around 250 ml. So if you want to calculate the index of oxygen consumption, then you have to divide by body surface area. But 3.5 ml per kilogram body weight is the oxygen consumption, and for a at rest, and for a 70 kilogram man, which is the standard taken, is around 250 ml per minute. Cardiac output can also be calculated from the formula. Cardiac output is equal to stroke volume into heart rate. There are many methods to find out the stroke volume. The simplest is by doing an echocardiogram, provided the patient does not have any regurgitant lesion. Because if the patient is having a regurgitant lesion, like let us say mitral regurgitation, the calculated stroke volume may not be the correct volume which is ejected into the aorta. It would be whatever is the volume of blood ejected into the aorta plus the regurgitant fraction or the regurgitant volume. So in a person where there is no, the valves are competent, where the valves are competent, cardiac output can easily be calculated from the formula stroke volume into heart rate, and echocardiogram is probably the simplest and the best method to calculate the cardiac output. The left to right shunt is detected by a significant oxygen step up in the particular right side chamber. So if you find an oxygen step up in the right atrium, you know there is a oxygenated blood is reaching the right atrium. Similarly, it can happen in the right ventricle or in the pulmonary artery. What is the level you consider as abnormal or detecting a shunt lesion for oxygen step up at right atrium? Any one of you? What is
Seven,
the
sir. Mean 7 and normally 11.
beg your pardon?
Highest is 11, mean is 7, sir.
5 to 11 mean is 7. What do you mean by that? I couldn't follow that.
If we are taking 3 samples and take a mean, then the step up considered abnormal is more than 7. But if we are taking only 1 sample, then step up should be at least 11.
Very good. That is in the atrial level, single sample 7 and multiple samples more than 7. Sorry, single sample 11, multiple samples more than 7. Okay. In the right ventricle?
It's 5 for the mean. If you are taking and for the single sample, it's more than 10. Sir.
More than
10.
No, you need not go up to more than 10. Even 7 more than 7 to 8 also is abnormal. So multiple samples 5, single sample 7 or 8. 8 is enough. If more than 7 is taken as abnormal. In the pulmonary artery?
5. Again 5 so for the mean.
Okay. Single sample?
And otherwise also 5. So
very good. So both in the pulmonary artery, both for single as well as multiple samples, it's 5. So you must be clear. One, the multiple sample atrium, it is 7. Single sample 11. On the pulmonary, on the ventricular level, multiple samples 5, and single sample is actually 7.5, so 7 to 8. And there's minor differences, but 7 to 8 above that level can be taken as abnormal. And for the pulmonary artery, both single and multiple samples, it is 5. Okay, on the right, on the left side.
Any shunt more than 2% is abnormal.
Very good, excellent. I think Navjot, I think you have got a very good concept. Very good. Any step up, any step down of more than 2, up to 2 can be taken as accepted as normal range, but any step down more than 2 is abnormal. So any at the atrial level or the ventricular level or the aortic level, a step down of equal to or more than 3 is abnormal. Right to left shunt is detected by significant oxygen step down in the particular left side of the chamber. Bidirectional shunt is detected by both the above observations. The following, whenever you analyze the pressure data, you have to analyze step by step. The points to be analyzed are the pressure in chambers or vessels normal? There are some normal pressures, the pressures which are accepted as normal in the right atrium, right ventricle, pulmonary artery, pulmonary artery wedge, left atrium, left ventricle, all those chambers. Whether the pressures in these chambers are normal. Is there a gradient across the valve when these valves are open? We don't expect a gradient, abnormal gradient. There are minor gradients can be there as we have discussed, but we don't accept a gradient above that level. Usually when there is a gradient, it can be explained by one, stenosis valve. Two, sometimes when there is a torrential flow across valves like pulmonary valve or aortic valve, sometimes we can get a gradient. But then you have to evaluate the whole scenario to decide whether it is due to a stenotic lesion or is it due to a very turbulent or increased stroke volume. Then are there any abnormal waves or any wave is absent? For example, in a patient with atrial fibrillation, you may not see an A wave in the right atrium. Or in a patient with tricuspid regurgitation, you may find a prominent V wave in the right atrium. So the wave pattern also should be studied. If there are any abnormal waves, that should be interpreted. And if a wave is absent, and that also should be interpreted. Are there abnormal equalization of pressure between chambers? Sometimes between various chambers, there can be abnormal equalization of pressure, and that may give you a clue to the diagnosis. Can any one of you quote few examples where systolic pressures can be equal? Yes?
Large VSD.
Large VSD or not. Large VSD may not be there. Okay, agreed. But the more, especially in a patient who has developed a VSD ascendment. So the pressures in the right the right ventricle, left ventricle, the pulmonary artery, and the aorta will be equal. So when all the four regions have equal pressure, then you should start thinking whether it is a large VSD, especially if the patient has gone in for ascending recession. Okay, right. Yes. Another condition?
Tetralogy of valve.
Yes. Which are the pressures equal?
PS.
Which are the pressures equal in tetralogy of valve?
RV and LV.
RV and LV systolic pressure and one more pressure.
Pulmonary artery.
No. Pulmonary pressure.
Aorta.
Aortic pressure. So right ventricle, left ventricle, aortic, systolic pressures are equal. Okay. Any other situation where there can be equalization of pressures?
Yes, like large unrestricted AST, there can be equalization of pressures in atria.
Okay, there can be equalization of pressure between right atrium and the left atrium, and consequently, then the diastolic pressures in the corresponding ventricles also will be the same. So in a large unrestricted ASD, there can be equalization of diastolic pressures in the right atrium and the left atrium. Very good. Yes, anything else?
Pulmonary atresia.
Maltresia, I agree that it will be some more the extreme form of tetralogy of Fallot. So you expect the systolic pressures in the left ventricle, right ventricle, and the aorta to be equal. One more condition you mentioned, then that's enough. Constrictive pericarditis.
Yes, sir.
Yeah, what is it?
Sir, it's the diastolic pressures which are equal in all the four chambers.
Okay, the diastolic pressures are elevated and it's equal in all the four chambers. What will be the difference which is acceptable?
So five.
Up to 5, yes, it's less than the difference between the difference in the diastolic pressure among all the four chambers, the right atrium, left atrium, right ventricle, left ventricle will be less than 5. If you are seeing a restrictive pattern and if the pressure difference is more than 5, then what is your interpretation?
It may be a restrictive cardiomyopathy.
Yes, it's a feature of the restrictive cardiomyopathy. While in constrictive pericarditis, the pressures will be less than 5, the difference will be less than 5. Okay, so these are the few things that you see by looking at the pressure data. If there is an abnormal equalization, you should start thinking in those terms. Then when you look at the oximetry data, are the oxygen saturation in various cardiac chambers normal? Is there a step up or step down, step up of oxygen saturation in any chamber or vessel? Is there a step down of oxygen saturation in any chamber or vessel? And then the calculation of shunt. Left to right shunt, right to left shunt. By looking at the oxygen saturation, you can get the ratio. So QP to QS ratio is systemic arteriovenous oxygen difference to pulmonary arteriovenous oxygen difference. From this, you can calculate the QP. QP can be calculated from systemic arteriovenous oxygen difference multiplied by QS divided by pulmonary arteriovenous oxygen difference. By calculating this, you can find out the ratio of the QP. And once you know the QS, systemic flow, the QP can be calculated. We'll do that as we proceed with the analysis. Bidirectional shunt calculation, this also should be very clear to you. Calculate the pulmonary flow. Calculate the pulmonary flow and the systemic flow. So pulmonary blood flow, systemic blood flow is calculated from the formula oxygen consumption per minute divided by arteriovenous oxygen difference per liter. Calculate the effective pulmonary blood flow. What is effective pulmonary blood flow? Any one of you? What is effective pulmonary blood flow? Which is equal to effective systemic flow. Any one of you?
Effective pulmonary blood flow is the flow which is finally going into the pulmonary circulation and is getting oxygenated.
Very good. The part of the blood which goes to the pulmonary circulation and gets oxygenated is the effective pulmonary blood flow. For example, if there is a shunt coming from the left atrium to the right atrium, that is already oxygenated blood. That blood cannot take part in the oxygen absorption, and the blood which is deoxygenated only can relieve carbon dioxide and take in oxygen. So the part of the blood which takes part in the oxygen transfer is the effective pulmonary blood flow, and which is equal to effective systemic blood flow. And the effective pulmonary blood flow, which is equal to effective systemic blood flow, is calculated from the formula oxygen consumption per minute divided by pulmonary venous minus mixed systemic venous oxygen saturation per liter. So oxygen consumption per minute, which is divided by pulmonary venous minus mixed oxygen saturation, mixed venous oxygen saturation, and that has to be converted to ml per liter, and that will give you the effective pulmonary blood flow, which is equal to effective systemic blood flow. Left to right shunt is pulmonary blood flow minus effective pulmonary blood flow minus effective pulmonary blood flow, and right to left shunt is systemic blood flow minus effective systemic blood flow. So by applying this formula, we should be able to calculate the bidirectional shunt also. Okay, now let's go over to some of the calculations. Pulmonary vascular resistance. You have to calculate the pulmonary vascular resistance also. Pulmonary vascular resistance means pressure drop across pulmonary vasculature divided by pulmonary blood flow. And systemic vascular resistance also is calculated from the formula pressure drop across the systemic vasculature divided by systemic blood flow. What is the normal pulmonary vascular resistance? What is the
so 1 to 2 wood units.
1 to 3 wood units.
1 to 2. 2 would be more correct. 1 to 2 wood units, or what is other unit? More correct unit?
It is dyne second per centimeter minus 5.
Raised to minus 5.
Dynes per centimeter raised to the power of minus 5.
Minus 5.
And that will be?
Sir, it will be around 80 to 160.
Yeah, 80 to 160, because 1 wood unit is equal to 80 dynes per centimeter raised to the power of minus 5. Okay. What is the systemic vascular resistance?
Around 1,000, around 800 to 100 dyne.
800 to? That is slightly low, Navjot. See, let us calculate it. What is the pressure drop across the systemic vasculature?
Sir, it is like mean aortic pressure minus right atrial pressure.
Yeah, it is a mean aortic pressure minus right atrial pressure. Normally, what is the mean aortic pressure?
So it will be around 80.
Huh?
So we will calculate it as systolic blood from 2/3 of diastolic blood pressure.
No, we did not go to minor calculations. So usually, in an adult, usually within 90 to 95. The mean aortic pressure is 90 to 95 because of 120/80. Roughly, it will be 90 to 95. For convenience, let us take it as 90. What is the cardiac output?
5 liters.
What is the usual cardiac output in a adult in the resting position?
Around 5 liters per minute.
Yeah, around 5 liters per minute. So, what is the pressure drop here?
So we have mean right atrial pressure around 3, sir, if it is normal.
Let's take it for convenience. Let us take it as 5. So,
Right.
90 minus 5 will be
85.
85.
Sir.
Divided by 5 will be 5 is the cardiac output will be 17 wood units.
17 wood.
So that will be usually around equal to 1,500 to it can go up to 2,500 wood units. Sorry, dynes per centimeter square or 15 to 20 wood units.
Right.
That's 15 to 20 wood units. That's the normal rate.
Right.
What will be the pulmonary vascular resistance and systemic vascular resistance?
So
What is it?
the ratio, sir?
No, I'm asking you what is the normal. The pulmonary vascular resistance is calculated from the formula. Pulmonary vascular resistance index is calculated from the formula. Pulmonary vascular resistance multiplied
By the body surface area.
body surface area. What is the normal pulmonary vascular resistance index? What is the normal?
3 to 6.
1.73 to 3.5.
7 to 3.5.
Yeah, it's about 1.7 to 1.8 to about 3.5. That is the normal pulmonary vascular resistance index. And what is the normal pulmonary systemic vascular resistance index? What is the normal systemic vascular resistance index? What is
25 to
the
30. 25 to
Beg your
30.
pardon?
25 to 35.
Right, very good. It's roughly around 22, 23 to 35. So you must know all those things. It should be very clear. Systemic pulmonary vascular examiners may ask you, is the normal pulmonary vascular resistance index. This is the only situation where body surface area is used to multiply the value or to get the index. Or everywhere else, it is the body surface area from the measured value. Body surface area is used to divide, and that will give you the index. Here is the only situation where pulmonary vascular resistance is multiplied by body surface area to get pulmonary vascular resistance index. So that should be very clear to you. Do you know why it is so? Why this pulmonary vascular resistance index is calculated by multiplying pulmonary vascular resistance with the body surface area? Any one of you? What is the formula for pulmonary vascular resistance? We have already put there. The pressure drop across the pulmonary vasculature divided by pulmonary blood flow. And then when you want to take pulmonary vascular resistance index, you divide by body surface area. So pressure drop across the pulmonary vasculature divided by pulmonary blood flow divided by body surface area. So when there is a double dividing, body surface area will go up. So that is why when you calculate pulmonary vascular resistance index, it is pulmonary vascular resistance multiplied by body surface area. I will repeat. Pulmonary vascular resistance is pressure drop across pulmonary vasculature divided by pulmonary blood flow. index is always calculated by dividing the value with body surface area. So pulmonary vascular resistance index is pressure drop across pulmonary vasculature divided by pulmonary blood flow divided by body surface area. When there is a double dividing, the body surface area will go up. So that is why when you calculate the pulmonary vascular resistance index, it is pulmonary vascular resistance multiplied by body surface area. Is it clear to you?
Yes, sir.
Is it clear? I
Yes.
think okay, right. Now we'll go to some case analysis. Volunteers, or different people can analyze. Start with this first case. We'll start with Navjot. Navjot, would you like to start with analysis?
Sir,
This is a simple
sir,
one.
sir, it's a 3-month-old child, sir. First, I'll read out that in the oximetry, the saturation is 94. There is slight desaturation. SVC is 70, so the cardiac output seems to be all right, sir. IVC 72. The RA is mean is around 70. RV is 70, again around 70. PA is 76. There is step up, but of around 6 significant step up at pulmonary artery level, and LA is 94, sir, and LV and femoral artery is also 94.
Is it normal?
And
Is it normal?
no, sir, it's not normal, sir.
Okay, right, yes.
As far as the pressure that is concerned, sir, RA pressures V is more than A, so that is abnormal, and
Okay.
also the pressures are also little raised, 7.5.
Okay.
The RV pressure is systolic pressure is high, that is 60, and corresponds to pulmonary artery. So pulmonary artery RV empties into pulmonary
No, but
artery.
before you go to that, you should also mention that there is no gradient across the tricuspid valve.
Yes,
Then
right.
it's complete because the right atrial pressure is A is 8, and RV pressure diastolic is 8. So there is no gradient across the tricuspid.
Tricuspid wall. So the pressure in the RV systolic pressure is high, sir, that is 60. Pulmonary artery systolic pressure is also high, that is 60, and there is no gradient across the pulmonary
good.
wall. The mean pulmonary artery pressure is 40, which is raised. And LA pressure A is 18 and V is 23, and mean pressure of LA is raised, that is 20.
Okay.
And LV pressure, its systolic is 85 and diastolic is 18. There is no gradient across the significant gradient across the mitral wall.
Very good.
The femoral artery pressure is 90 and diastolic is 50. Again, there is no gradient across the aortic wall.
Very good. Okay. What is your diagnosis? Put the hemodynamic diagnosis first, and then you come to the clinical diagnosis. But what are the hemodynamic abnormalities that you have found out? There is a mild elevation of the
mean pulmonary artery pressure is raised, sir.
Yes, pulmonary artery, RV systolic pressure is elevated, pulmonary artery systolic pressure is elevated. There's a mild elevation of the mean right atrial pressure. There is significant elevation of the left atrial pressure.
Mean pulmonary artery pressure, sir. And also the LA pressure is also raised,
Okay.
sir. And then there appears there is a significant step up at pulmonary arterial level.
Very good.
So there is
and also there is a step down, or rather there is a decrease in the oxygen saturation in the
left-sided pressure, sir. So
right,
left atrium, sir.
Left atrium, left ventricle, and femoral, they are all same.
Hanji, sir. But the saturation, we should have got, it should be at least 90, more than 98, sir.
Okay, very good.
Lesser.
Yes.
So the one significant, the patient has a pulmonary artery hypertension with the step up at pulmonary arterial level, and also a step down, maybe. I would like to consider as my first DD for the clinical diagnosis as a PDA with bidirectional shunt, sir.
Why did you say PD with bidirectional shunt? Because in PD with bidirectional shunt, what will you get? There should be step down at the
Step down, sir. Yes, it should have been a step down at the femoral artery level, sir.
yeah, there is no step down.
There is no step down, sir. Yes, sir. There is no step down.
Would you like to slightly modify PA? For example, this is only 3-month-old child. So, okay, right. We'll discuss at the end. Right, okay. What else? You have to explain the lower oxygen saturation in the left side of the chambers.
Yes, sir. Sir, either one is we have to rule out the some pulmonary lung disease because we don't have a pulmonary venous saturation, sir.
Okay.
We can't rule out a parenchymal lung disease.
Oh, okay.
Uh,
Why can't you think about the LV failure? Because the left atrial pressure is here itself is elevated, and quite possible that intermittently it is going to a stage where the patient can develop interstitial edema or even pulmonary edema or breathlessness, which can bring down the oxygen saturation. Why can't you think of that?
Sir, but why should there be a step up at pulmonary arterial level?
No, that's a different thing. That is separate. So pulmonary artery level, I agree with you with left to right shunt at the pulmonary artery level. But of the two, what are the things which can actually cause a PA oxygen step up in a child of this age?
So one is PDA, sir.
Other is
AP window, sir.
AP window. Yes, AP window. Of the two, which one you think is more likely?
AP window.
AP window. AP window.
Because femoral, yes, sir.
Yeah, the child has at the 3 months started developing even desaturation, the LA pressures are elevated, the patient has started developing pulmonary arterial hypertension. All those things put together, I think you think, of course, you can discuss as left to right shunt at the pulmonary artery level, more likely to be AP window than
The
PD.
right.
And the oxygen desaturation in the LV pulmonary artery, as you rightly discussed, maybe due to lung disease because the pulmonary venous oxygen saturation is not given, or it may be because of the pulmonary congestion. The child is having evidence of some degree of pulmonary congestion secondary to LV failure because LV and vascular pressure is 18. So obviously it is grossly elevated. So that may be the reason that the patient is having some degree of desaturation in the left side of the chambers. Very good. I think you did very well.
Right.
Any doubts about the points that we discussed, or can we go to the next one? Okay, we'll go to the next one. One volunteer. I need a volunteer. Sorry. Okay. Volunteer. Anybody? Rajesh, anybody from Leelavati? There was I forgot his name. Ramesh. Is Ramesh there?
Yes, sir.
Ramesh, why can't you try?
Okay, sir. It's a 12-year-old female.
Oh.
I will like to analyze the pressure data first, sir.
Okay.
In RA, there is VO is more and slightly elevated pressure. Mean pressure is 9.
Okay.
Then RV.
So what may be the reason?
There could be. I have to analyze whole, sir.
Okay,
could
fine.
be because of shunt or anything.
Okay.
Then RV systolic pressure is significantly high, 120/70, and there is no gradient across the tricuspid. 120/7. 120/7.
Okay, right.
And there is no gradient across the tricuspid wall.
Very good.
RV pressure is 50/7.
Flow and outflow.
Inflow and outflow. Sorry, RV inflow is 120/7. RV outflow. So there is gradient in the mid RV.
Okay.
Maybe from RV to.
There is a gradient across the RV outflow.
Yes, sir.
The inflow is pressure systolic is 120. RV outflow pressure is 50. So there is a gradient there. Okay, very good.
Yes.
Infundibulous gradient. Okay, right.
Yes.
Yes.
Sir. Then there is a PA pressure is 20/8. Mean is 11. So there is again gradient across the RV outflow and PA.
Okay.
30 mm Hg. Then pulmonary artery wedge pressure is mean is 8. Borderline.
No, that is normal.
Yes.
Pulmonary wedge 8 and mean 8 is normal. Normal up to 11.
Yes.
Up to you can take up to 11 as normal. This is definitely normal. Okay.
Yes, sir. LA pressure is normal.
Okay. Very good.
Aortic pressure is 120/75. Mean 90. It's normal.
Okay.
And LV pressure is 120/7. That is also normal.
Okay.
So there is a significant gradient from RV inflow to outflow and outflow to the pulmonary artery.
Is there an abnormal equalization of pressures?
Yes, sir. There is a abnormal equalization of pressure in the RV and LV.
Systolic pressures of
Systolic
RV,
pressure.
RV inflow,
RV inflow and LV.
LV and
aorta.
Aorta is equal. So,
Yes, sir.
and there is a gradient across the RV outflow.
Yes, sir.
It goes consistent with what?
It's consistent with the TOF, sir.
TOF, very good. Okay, right. Now we have to look at whether it is our other findings support TOF or not. Yes.
Yes, sir. So body surface 1.2 meter square. Hemoglobin is 17 gram percent. 17.
17. Okay, right. Yes. Okay.
17. Oxygen consumption is 180. So in oximetry, SVC saturation is 55 and 54. SVC, then IVC is 66. RA is 61, RV is 61, pulmonary artery is 60. So there is no significant step up or step down at the from SVC up to the pulmonary artery.
Okay.
But pulmonary artery wedge is 100% and LA is 90%.
Okay.
So there is a step down from wedge to LA.
Okay,
and
very
there
good.
is again step down from LA to LV.
Okay, very good.
And from LV to the aorta.
Diameter maybe 2, maybe may not be a step down because you need 3 or
yes, sir.
more than 2. Okay, right? Yes. So you interpret it. How do you calculate the mixed oxygen saturation, mixed venous oxygen saturation?
Mixed venous oxygen saturation we calculate by 3 SVC plus IVC divided by 4, sir.
Okay. How do you calculate that?
We have to take the SVC saturation, then 3 times the SVC saturation plus IVC, that is 55 plus 55 plus 55 plus 66 divided by 4. So,
you don't have to do all these things. You find out the difference between SVC and IVC.
Okay.
Divided by 4. Divide by 4 and add that to SVC.
Okay, sir.
For example, 54, simplest is 54 and 66 is, difference is?
It is 11, sir.
51, but not 55. 54 and 66 is 12.
Yes, sir.
Divided by 4 is?
3.
3. So you add 3 to 54, it will be 57.
Yes.
You don't have to multiply by 3 and add and all. You find out the difference between SVC and IVC, divide by 4, and that is added to SVC. That will give you the
Mixed venous oxygen
saturation.
saturation.
So here it is 57. Okay, right?
Yes.
Yes.
So I have to calculate the.
No, but you now from the oximetry data you will find out. Do you have a calculator with you?
No, sir.
Oh, if you had come, I forgot to tell last class that you should come with a calculator. Now tell me what is your diagnosis and tell the formula for calculation of systemic flow, pulmonary flow. Anybody having calculator, because you should calculate all those things.
For pulmonary flow, we have to see the first
No, but tell
oxygen
me
consumption.
first. No, tell me your diagnosis first.
Yes, sir. So it's a tetralogy of Fallot, sir.
Okay, okay.
With infundibular and valvular pulmonary stenosis.
Very good. Anything more?
There is a little LV step down.
Why there is a step down at LA?
It's maybe because of the collateral circulation, sir.
Collateral. LA step down from the pulmonary artery wedge to LA step down is because of the collateral circulation.
It may be because of systemic venous to LA drainage.
Okay, in the pressure data, already LA pressure is recorded. LA pressure and the RA pressure are almost equal. Of course, RA pressure is slightly higher, V wave is slightly higher. And what is the additional lesion that we can think about?
Yes.
AST. Patient may be having
But
associated.
there is no significant step up at the RA level, sir.
No, that is only when there is a flow from left to right. In a patient with pathology of
Yes,
it will be
yes, sir.
right
It
left.
will be it will be reversed.
So there is an oxygen step
Shunt
down
at the
LA level.
atrial level.
So this, when you have got AST, also some people call it as
Pentalogy fellow.
Pentology fellow. Okay. And what is the explanation for a slightly taller V wave in RA?
AST.
It is because of the ASD, sir.
Oh, how can there be tall V wave in right
Probably
atrium in the
because of PRs.
Oh, the patient may be having mild. It has been well reported. And patients with pathology of fellow, some of them can have PR also. So it may be because of the tricuspid regurgitation. So this is a full diagnosis. It's a case of pathology of fellow with a gradient across the both infundibular and valvular stenosis. Then there is probably there is some degree of tricuspid regurgitation, and there is associated atrial septal defect. And then how will you calculate the systemic flow?
For systemic flow, we have to take the oxygen consumption divided by arterial mean arterial saturation minus mixed venous oxygen saturation.
You tell me the formula. That's enough. You need not calculate it, but tell me the formula. In this
Yes,
patient, it will be oxygen consumption is 180
ml per
minute. Okay.
That we have to multiply by 1.2. 180 multiplied by 1.2.
No. Why do you want to multiply 1.2?
That will be total oxygen consumption.
No. Here it is not written per meter square body surface area. Oxygen consumption is 180 ml per minute. That is the total oxygen consumption. It is not written. It is per meter square body surface area.
Okay.
Because it's a 12-year-old child.
Yes, sir. So 180 divided by 80 minus 57.
80 minus.
That mixed venous we have taken as 57.
No. See, I wanted you to calculate pulmonary blood flow. Your systemic blood flow. All right.
Systemic blood flow.
Okay. 80 minus 57.
For pulmonary blood flow, 180 divided by.
No, that is not enough. You have to tell the whole formula.
1.36 into hemoglobin is 17 into 10.
Into 10? Into 10 where?
1.34.
Deciliter.
No. Formula is not correct. Repeat. We please repeat the formula.
180 divided by. Sir, 180 divided by 80 minus.
No, don't write put 80 minus and not. You put it as 80. Calculate it is 23. It's not so. 80 minus 57 is 23.
Okay.
23 is the difference in oxygen saturation. That has to be converted into ml per ml of oxygen. How do you convert it to ml per oxygen?
1.34 into 23.
1.36. Because that will look after the dissolved oxygen also. 1.36 into
23 into 10 into hemoglobin, that is 17.
Where did you get this 10 from?
It is per liter. We have to convert into deciliter, sir.
Okay, right. Multiplied by 10. Okay, right. Yes. So that will be the formula. Okay, so you have to multiply it. Actually, you have to that is not correct. There is something more. No. Not enough.
Then we have to add the dissolved oxygen also, sir. 0.03.
1.36 will include the dissolved oxygen also. That is not correct.
Partial pressure of oxygen, sir. Multiple.
No. 10 is not below, 10 is above. See, the formula is, let us say, oxygen saturation, oxygen consumption divided by arterial oxygen difference. What is arterial oxygen difference? We have only got oximetry data here, so that we have to convert into ml, convert it into volume. So the arterial oxygen difference on the systemic side here is 23%. That
Yes,
means
sir.
23 divided by 100 multiplied by 1.36 multiplied by oxygen hemoglobin 17 multiplied by 10. We have to convert it into liters.
Yes, sir.
Here there is 100 below, so 10 and 100 will get crossed each other. So that will becomes 10, and 10 will have to go up.
Yes.
So the oxygen consumption multiplied by 10 divided by 23 multiplied by 1.36 multiplied by 17 will give you the systemic blood flow. Is it clear to you how the formula was derived? I will repeat. First is oxygen consumption, 180 ml per minute, divided by arterial oxygen difference. What is arterial oxygen difference? We have got the hemoglobin, then we have got the oxygen difference in oxygen saturation. So from that we can calculate the oxygen volume of oxygen per liter. The difference in the volume of oxygen between the arterial blood and the venous blood per liter. That can be calculated. One, arterial oxygen difference is 23 here. So 23 multiplied by 23 divided by 100 multiplied by 1.36 multiplied by 17, and this has to be converted into liters multiplied by 10. And this 10 will be crossed with 100, so there will be 10 below. And since there is a, it is below, it is whatever is in the denominator is divided by 10. This will go up, so that will become the oxygen consumption multiplied by 10 divided by arterial oxygen saturation difference, that is 23, multiplied by 1.36 into 17 to convert it into ml per liter, ml per 100 oxygen in ml per 100 ml, multiplied by 10 to make it in liters. So that you will get the pulmonary systemic flow. Okay. How will you calculate the pulmonary blood flow?
Same, sir.
Same
VO2
formula.
divide.
Only thing is that instead of 23, you will use what will be the value that you will use here?
So we'll take the pulmonary venous.
40, sir.
40. Very good. Okay. So, and you must also, you should have calculated the pulmonary vascular resistance and pulmonary vascular resistance index also. Then that would have been complete. If somebody is having a calculator, or most of your phones will have a calculator.
Yes,
Okay,
sir.
next case let's calculate it, and only it becomes complete. Okay, any volunteers to analyze this pressure data? Any volunteers? You must try to analyze it. Then only you will be become proficient enough to recognize the abnormalities. And Shraddha, are you there? Dr. Shraddha, are you there? Anybody who would like to analyze the data? None? Okay, then we will ask already those people who have analyzed it, they can try, because unless you analyze it, you will not become proficient to detect abnormalities. Now, Joe, would you like to try?
Hanji, sir.
Okay.
So she's a 25-year-old female, and the pressure in RA is more than V, and mean RA pressure is slightly raised. The RV pressure is 45/6, and there is some gradient.
Small gradient is abnormal. It is abnormal. A is actually 10, mean is 8, and RV and diastolic pressure is 6. So there is a gradient. Okay, yes.
And the pulmonary artery pressure systolic is 45, diastolic is 20, mean pulmonary artery pressure is 30, slight raise, and there is no gradient across RV and pulmonary artery.
Very good. Excellent.
Pulmonary artery wedge pressure is A is 18, V is 14, and mean pulmonary artery wedge pressure is 16. Again, slightly
Do you
raised.
think that this patient has got what is the cause of pulmonary artery pressure elevation?
There is an element of post-capillary increased blood pressure, increased pressure also, sir, because pulmonary capillary wedge pressure is raised, sir.
Okay, so now I am asking a question. Is it all only pure passive elevation of pressure, or do you think that there is a other elements are also coming in?
So for that we have to calculate, see the diastolic pressure gradient. I mean, if it is if it is only pre-capillary, then the pulmonary capillary wedge pressure should be less than 50.
No, it is.
But here
It is definitely post-capillary. That is there. I am
post-capillary.
asking a question. See, whenever there is a pressure elevation in the secondary to a left-sided disease, it can be one passive elevation of the pulmonary artery pressure, or it can be a reactive and protective vasoconstriction, and also sometimes it can be obliterative type of vascular reaction resulting in pulmonary artery pressure. I am asking a question: is the pressure elevation in this patient purely a passive elevation, or other components are also there? Or I am asking a question: how can you recognize it? The recognition is that if the pulmonary artery diastolic pressure is equal to the pulmonary artery wedge pressure, that is most likely it is only pulmonary venous pressure, passive venous pressure elevation. But if there is if the pulmonary artery diastolic pressure is more elevated than the pulmonary artery wedge pressure, mean wedge pressure, that obviously means that there may be some degree of pulmonary vasoreaction. Here, actually, pulmonary artery diastolic pressure is 20 and pulmonary artery wedge pressure is 16. Only minor difference. So mostly it is a pulmonary venous, so passive pulmonary arterial pressure elevation. It is secondary to elevation of the pulmonary venous pressure. The passive elevation of the pulmonary artery pressure. I will repeat. You should look at the pulmonary artery diastolic pressure and also look at the pulmonary artery wedge pressure. If it's almost equal, up to 5 can be taken as almost equal. If it is equal, then you will consider that this is only secondary to a passive elevation of the pulmonary arterial pressure. But if there is a significant elevation, that obviously means there is a pulmonary vascular reaction. Here it mostly seems to be a passive elevation of the pulmonary arterial pressure, secondary to pulmonary venous pressure elevation. Okay, right? Yes. Could you understand it now, Joe? Could you get the point? Hello?
Hello?
Oh, can you hear me?
Yes, sir. Yes.
Could you get the point? Could you understand?
Yes, sir.
Okay, right. Yes, go ahead.
So then the LV pressures is 130 and 6 is the EDP. So if we take LA pressure, mean LA pressure as 16, there is a significant gradient across the mitral wall.
No, there is no LA pressure here.
Sir, that's why I'm assuming the wedge pressure as the LA pressure.
Okay, very good. What do you mean by wedge pressure?
So wedge pressure is when we basically, so we are taking the catheter and wedging it inside it reflects the capillary pressure and the LA pressure and the usually the wedge pressure has to be equal, sir, or slightly.
See, the pulmonary artery wedge pressure is measured by moving the tip of the catheter to the smallest arteriolar branch and where it is obstructed. And then you will get the reflection of the pressure in the pulmonary venous system. And usually pulmonary arterial blood pressure is almost equal to left atrial pressure. At the most, there may be a difference of 1 millimeter. Okay, very good. Yes. So here you are getting pulmonary arterial wedge, and there is a difference of more than 10 millimeters or equal to 10 millimeters, indicating that there is a obstruction to
the flow from LA to LV, sir.
Okay, very good.
So the iota is LV's systolic is 130, iota is 105. So there is a gradient of around
why did you use the word around? You should not use it. You should say that there's a gradient of 25.
25 across the iota.
Don't use unnecessary words where it is not required. So here you can definitely calculate this 25. Don't use the word around. It's 25.
Right.
Yes, good.
So hemoglobin is 40, and then coming to the oximetry.
No. Let's find out from the pressures what do you think is the problem.
So there is slight pulmonary arterial hypertension. Probably it's passive due to passive congestion.
Okay.
There is a slightly raised pulmonary capillary wedge pressure, and there is a significant gradient across between LA to LV, and some gradient between LV to iota.
And also there is a small gradient across the tricuspid wall also.
Tricuspid wall also.
What are these gradients? What will be your interpretation? What will be the lesion?
So probably the patient might be having a mitral stenosis.
What is the severity?
So it will be moderate to high, sir, because 10 is the gradient.
Yeah,
sir.
10 is the okay. Moderate, may not be severe. Moderate, okay. Moderate mitral stenosis. Okay, very good. Yes.
And then also there may be a lesion across the tricuspid wall. There may be a organic tricuspid wall lesion also, sir.
Very good. That is seems to be only 2 millimeters, so it's a mild tricuspid stenosis, and across the aortic valve.
And across the aortic wall again, so the grade there can be mild AS also, sir.
Mild, okay, right. So.
And so the coming to the oximetry, the pulmonary artery saturation is 72%, and iota is 96%.
Okay.
Oxygen consumption is 250 ml per meter square, and
2 ml per minute.
Per minute, sorry. So 250 ml per minute, and hemoglobin is 14, sir. So, probably it looks like seeing iota is 96%, so there is no major desaturation.
No, there may be mild desaturation because after 98 is acceptable, 96 slightly on the lower side. Maybe there may be some lung congestion which has resulted in some degree of desaturation. Not significant, right? Yes.
So the probable diagnosis with the given cat data is the valvular lesions, moderate MS, mild AS, and mild TS.
What about the cardiac output?
So
from say by looking at the aorta and the pulmonary artery oxygen saturation, what do you think is the cardiac output of this patient? Is it normal, decreased, increased?
Sir, it appears to be normal, sir, because 72 is the pulmonary artery saturation. So anything more than...
You look at the arteriovenous oxygen difference. Any arteriovenous oxygen difference of between 20 to 25, near about 25 can be taken as normal. So 20 to here it is 24. So cardiac output is definitely
normal.
Very good. I think you analyzed it very well. So we'll go to the next one. I want a volunteer, somebody else, to analyze. Any other anybody who would like to take up the challenge? Forgetting your names. Anybody can take one, and I will also help you to analyze it.
Hello, should I interpret, sir?
No, please. What is your name?
I'm Dr. Hafeesh Bhatia. I'm from Jaipur, sir.
Okay, please. You interpret it, and then only by interpreting you will get the confidence, experience to look at the data. Okay, that is.
So it's a 12-year-old female,
Oh.
sir. The RA pressure is A wave is 8 and B wave is 8. Mean is also 8.
Okay.
Coming to RV pressures, inflow is 120 divided by 8. So there is no gradient across the tricuspid valve.
Very good. Excellent. You are doing very well.
RV outflow pressure is systolic 40, diastolic is 8. So there's a significant infundibulous
Very good.
stenosis.
Excellent.
Pulmonary artery pressure is 40 systolic, 20 diastolic, and mean is 26. So there's no valvular pulmonary stenosis.
Very
here.
good. Excellent.
Now coming to
you must interpret PA pressure. Is it normal or elevated?
PA pressure is mildly elevated, sir.
Mildly elevated. Very good. Excellent. Very good.
Coming to wedge pressure, A wave is 8, A wave is 9, V wave is 8, and mean is also 8.
Okay, very good. Yes.
Okay. Now coming to LV pressure.
That is normal. That is pulmonary artery wedge pressure is?
Pulmonary wedge pressure is slightly elevated, sir.
Oh, no,
No,
it
it's
can be
normal.
passed as normal.
Normal,
See,
normal.
in adult up to 11 is normal. This is child
Yes.
still, I would consider it as will positive as normal. Okay, right? Yes.
Yes, sir. LV systolic pressure 120, diastolic 8, so no gradient across mitral valve as well.
Very good, very good.
And aortic systolic pressure 120, diastolic 70, so mean is 84, normal, so no gradient across aortic valve.
Very
also.
good, excellent. I think you are doing very well. I think you are very confident also. Excellent. Okay, right? Yes.
Now, coming to the
oximetry data. Hello. Suddenly I can't hear you. What happened? I can't hear you. Hello. Vadia, I can't hear you. Now, Joe, can you hear me?
Yes, sir. Yes, sir. I can hear you.
Can you hear Dr. Vadia?
No, sir, no.
No, has he muted himself? Hello, central the people who are controlling the. Okay, can you find out what has happened to the to Dr. Vadia?
Just a second, doctor. Let us find out.
Okay, I
hello,
can't hear
sir.
him.
Sorry, I lost connections. I came back. Can I go ahead?
Oh yeah, please.
So coming to oximetry data, high SVC is 60%, low SVC is 61, IVC 64, RA 61, RV
What is
62.
what is the mean oxygen saturation here?
Mean oxygen saturation will be difference is 4, so 4 divided by 4 1. So mean will be 61, okay. Sir.
Very good, excellent. So that is only thing you have to do. You can find out the difference. 64 minus 64 divided by 4. That is added to the SVC oxygen saturation. So 60 plus 1, 61. Okay, this is the simplest.
Yes.
Yes.
Now there's a step up from RV to pulmonary artery of 8. Wedge pressure is 99%, but there's a step down from wedge to LV. Since we do not have LA saturation, we can assume that the step down is at the ventricular level of 13%. Then aortic saturation is 85%. There's no further step down. Okay. So
is there any abnormal equalization of pressures?
Abnormal equalization of pressures.
Is there any abnormal? Yeah. What is it?
RA and LA pressures are equalized.
No. Abnormal equalization. What is RV, LV, and aortic systolic pressures?
RV, inflow, LV, and aorta.
Yeah.
Here,
systolic pressures of RV inflow, LV, aorta are equal. So what is the condition in which we can get these pressures now equal? Top. So, yes, so here, do you think that everything is consistent with pathology of fellow? There is something abnormal.
PA pressure.
There's a step up at PA level.
Oh,
that
very
is
good.
abnormal.
So how will you explain that?
Yeah. So due to collaterals, that is possible. There might be aortopulmonary collaterals which could give rise to step up at the PA level.
Okay, but usually collaterals may not be enough. See here, this patient has started developing pulmonary vascular changes because the PA pressure has gone up. The collaterals occur when there is a very significant reduction in the pulmonary blood flow and very unlikely to give rise to an elevation of the pulmonary arterial pressure. Rarely it can happen, but not usually. So whenever you find that the pulmonary artery pressure is elevated, you should always think of a man-made shunt.
Right.
So here, what is the man-made shunt which actually can cause a pulmonary vascular reaction?
BT shunt.
BT shunt usually will not. Of course, BT shunt can. But nowadays, BT shunt is not done. What is the type of shunt that is being done? Modified BT shunt or Gore-Tex.
Yes, sir.
What is the difference?
A conduit is used here, sir, in the modified.
Conduit is used, and also by the anastomosis in BT shunt, it is what type of anastomosis?
End-to-end anastomosis.
End-to-end anastomosis. What is that anastomosis? End-to-end. Who said that end-to-end?
BT shunt is end to side.
It is end to side.
End to side.
End to side.
And in Gore-Tex shunt, it is
Side to side.
Side to side.
Side to side.
Side to side.
So you have to sacrifice the subclavian artery. Subclavian artery it is end to side anastomosis in BT shunt. In the modified BT shunt, which is Gore-Tex shunt, it is actually side to side anastomosis. But usually in Gore-Tex shunt, very unlikely that they will go in for pulmonary arterial changes. So whenever there is pulmonary arterial changes, you should start suspecting the patient might have received a central shunt. And what are the central shunts that are man-made shunts?
Water shunt.
Watterson and Pod.
Watterson and Pod shunt. So here you should think of the possibility that this patient may be having a shunt done at an early childhood and must have been a central shunt. Okay, now actually you should calculate the right left shunt. Well, at least you tell me the formula for pulmonary vascular resistance.
So
because here, when you consider that this patient, whether the patient should be taken up for a total correction, you should have an idea what is the pulmonary vascular resistance and is there any significant vascular changes which has taken place. All those things should be looked into.
Yes, sir. So formula for pulmonary vascular resistance is mean pulmonary artery pressure minus pulmonary capillary wedge pressure divided by pulmonary flow.
That's right. You should always use the word it is not pulmonary artery wedge pressure. It is the mean pulmonary artery pressure minus left atrial pressure. And when the left atrial pressure is given, you should take left atrial pressure. But in the absence of left atrial pressure, pulmonary artery wedge pressure can be taken as the as equal to left atrial pressure. Okay, right? Yes. So here it is the formula is 26 minus
26 minus 8 divided by pulmonary flow.
Okay, very good. Okay. So since you don't have a if somebody is having a calculator, we could have done that also would have been complete. Okay, so this is a pathology fellow with most likely a central shunt which has given rise to the step up at the pulmonary artery level, and also this has resulted in some degree of pulmonary arterial reaction resulting in pulmonary artery pressure elevation. Okay, right. Very good, body. I think you did very well. You are very confident also. Excellent. Very good. We'll go to the next one. No. Yes.
LV desaturation at LV level.
What is the reason? May I know your name?
Radhakrishnan.
Radhakrishnan. Radhakrishnan, how can there be an LV desaturation? You should answer it.
Wider.
Oh, there is a shunt coming from right to
RA to right to left.
RA. RV to LV. That is what is happening in pathology fellow. There can be bidirectional, but there is a definitely desaturated blood from the RV is coming to the LV. That is why we definitely that also should be looked into in pathology fellow. In addition to equalization of pressures, you should look at there is a step down of oxygen saturation at the LV level.
There should
So
be
here is a, so LV is 86%. That is an additional point for us to confirm the diagnosis of pathology of fellow.
there should be RV step up
Clear,
also.
others?
If there is
What step up?
if there is bidirectional shunt, there should be RV step up also.
Usually there will not be, but that bidirection is only when you might have done a lot of echo on pathology of fellow. Sometimes there can be minor left to right shunt during diastole, but that will not give rise to any step up. That will not be enough to give rise to a step up. Usually, it is a majority, mostly it is considered as the right left shunt, not as the left to right shunt. But if you do an echo, you can always find that there is a small degree of bidirectional shunt also there. But that will not be enough to give rise to or to detect any step up at the RV level. What you will find only is a step down at the LV level. Okay. Any other doubt? Radhakrishnan, where are you from? Which institution?
Kotte Medical College.
Kotte Medical College. Okay. Right. Okay. So the LV desaturation is because of the right left shunt in the pathology of fellow. Okay. Right. We'll go to the next one. Any doubts? Okay. We could have actually looked at the right left shunt, left to right shunt, and also calculated the exact amount of bidirectional shunt occurring at both directions. Here there is a left to right shunt at the level of the pulmonary artery and the right left shunt at the level of the ventricular level. So okay, right. We'll go to the next one. Radhakrishnan, why can't you try so that you will get experience? Radhakrishnan, why can't you try to interpret the data? I will help you. Are you able to hear me?
Yes, sir.
Try.
Left.
Are you trying or should
Yes,
I
sir,
ask
left.
some? Okay, right. Yes.
Left innominate vein. Sir, A is 14. B 14.
Okay. Meena?
And high superior vena cava.
No. You have to say whether it is normal or abnormal. The nominate vein pressure A14, V14, and mean 13 is it is abnormal. It is elevated. Okay, very good. Yes.
High superior vena cava 8 and V is 8. Elevated, sir.
ISV say 8 borderline elevation, maybe not grossly, but I also agree there is a borderline elevation. But more important point is there is a gradient.
Gradient between this innominate vein and ISVC.
Very good. There is a gradient across left innominate vein and ISVC. Very good. Yes.
And low SVC is A wave is 8 and E wave is 8.
Okay.
Equals no gradient between.
Right.
And RA A wave is 7 and E wave is 8. Sir.
Mean
V is 8. Sir.
Okay.
And mean
6. So there is no gradient. Okay, right. Yes. LA.
LA A wave is 7 and E wave is 8. Mean is
equal
6.
to exactly same as right atrium. So there is a unobstructed large AST. Very good. Yes. Okay.
RV pressure systolic is 40. Diastolic is 6.
Is it normal?
Rise in the systolic pressure.
Okay. Systolic pressure is elevated. Very good. Yes.
Pulmonary artery pressure. Systolic is 40, diastolic is 18, and mean is 26.
That is elevated. Very good. There's a mild elevation of the pulmonary arterial pressure. Okay, very good. Yes.
Pulmonary artery wedge pressure A is 14 and V is 14.
And
elevated.
Very good. Excellent. LV?
LV pressure, systolic is 100, diastolic is 6. Normals.
Okay.
And gradient between the capillary wedge pressure, pulmonary capillary wedge pressure and LV.
Okay.
About 8.
Okay. What does that mean?
And there is a mitral stenosis at mitral.
No, but your LA pressure is only 6.
Nice.
Your LA pressure is A7, V8, and 6. So why do you want to diagnose mitral stenosis?
Sir, in the between the pulmonary vein and
Pulmonary vein and
LA, sir.
You have to interpret it. Don't jump to conclusion because there is no gradient between LA and LV diastole. So obviously mitral valve is normal.
Yes, sir.
Okay, we'll interpret it gradually. Okay, what about the aortic pressure?
Aortic pressure systolic is 100, and the diastolic is 70.
And main of yeah. So that is it
no
normal?
Gradient between this LV and diastolic.
Okay, is it normal?
Normals.
Okay, right. Yes. So what are the abnormalities in the pressure data?
There is a gradient between the innominate vein and high superior vena cava.
What is the condition in which you can get that?
Obstruction at the level of superior vena cava obstruction.
Superior vena cava obstruction, yes. Can you think of any congenital heart disease where there can be a gradient at the level of the as the innominate vein joins the superior vena cava?
TAPVC with obstruction.
Yes, supracardiac type of
Supracardiac.
total anomalous pulmonary venous drain. That you should keep in mind. We are going to oximetry data. From the pressure data we had, then you have to explain why there is a difference between PA wedge and LA pressure. Adashnan, you have to think. Oh.
Yes, sir.
PA wedge pressure is equal to what pressure? Innominate vein pressure and PA wedge pressures are? The innominate vein pressure and the PA wedge pressures are?
3 here.
Left innominate vein pressures and pulmonary artery wedge pressures are?
Same almost.
They are equal.
Equal.
So obviously the pulmonary artery, the pulmonary veins are actually is connected to the innominate vein rather than to the left atrium.
Yes, sir.
And left atrium and right atrial pressures are equal. So what does that mean?
Non-restrictive.
Very good. It's a non-restrictive AST. Okay. Now, so we have drawn few conclusions. So now we have to look at the oximetry data. So what is the oximetry data that will help you to diagnose supracardiac type or total anomalous pulmonary venous drainage, especially supracardiac variety?
Yes, sir.
What is the oximetry data which will help you to diagnose supracardiac variety of total anomalous pulmonary venous drainage?
High saturation at the left innominate vein saturation
in almost all chambers.
Yeah, that's the most important point. There will be the oxygen saturation in the right atrium, left atrium, left ventricle, right ventricle, pulmonary artery, aorta. All will be almost the same. And also in supracardiac variety, the pulmonary arterial oxygen saturation can be higher than that of the pulmonary venous oxygen saturation. Sorry. Pulmonary arterial saturation can be higher than the aortic oxygen saturation. Can you give the explanation? Any one of you? Now, Jyoti, would you like to try that to answer that?
So because all the pulmonary veins in supracardiac type of TAPVC, they're coming to the right atrium and the right ventricle. So because of the streaming effect from the right atrium, it will go to the right ventricle, the oxygenated blood. So we may get a higher oxygen in pulmonary artery as compared to the LALV because of the streaming, sir.
What you have to explain the streaming.
IVC blood flow will be directed towards LA.
Very good. That's the point. See, it is a supracardiac variety of venous drainage. So the blood coming from the superior vena cava preferentially flows to the right ventricle, and blood coming from the inferior vena cava preferentially flows to the left atrium. That is the direction of flow. So
Yes.
because of that, the oxygen saturation in the aorta can be slightly less than the oxygen saturation in the pulmonary artery. Can you tell me other situations where the pulmonary artery oxygen saturation can be higher than the aortic saturation? There are two more conditions.
TGA physiology.
TGA physiology. Or one you say TGA.
So,
Another is it's a TGA physiology itself. What is it? Toxic being an anomaly.
toxic.
There are only three conditions where the pulmonary artery oxygen saturation is more than that of the aortic saturation. They are: one, transposition of great arteries; transposition; two, toxic being anomaly; three, total anomalous pulmonary venous drainage of the supracardiac variety. So once you see this, you should immediately think that one of the three should be fixed. Okay. Now Radharshan, continue with oximetry.
Left innominate vein, high level saturation is 64. Left innominate vein, lower level saturation is 92%.
Okay.
High SVC, 92% saturation. Low
Okay.
SVC, 91%.
Oh.
Then right atrium, 88%.
Why did it
Right
drop? Why did the oxygen saturation drop there? Is there a shunt there? What does really happen? Why did it drop?
Here that
IVC.
Very good. IVC. Now that's why you should always start thinking. There is IVC blood has come to right atrium, and so
Yes,
the oxygen saturation has fallen. Okay, right. Very good. Yes, very good. So now, Jyoth, very good. Excellent. Very good. Yes, continue.
then RV 87%.
Hmm.
LA 87%.
Hmm.
Pulmonary artery 88%.
Hmm.
The LV is 86%.
Hmm.
IVC is 66%. Aorta is 85%.
85%. Okay, right. So pulmonary artery oxygen saturation is slightly more than that of the aortic oxygen saturation. Okay. Yes. Now you put and you tell me what is the diagnosis?
That high left innominate vein 64, and there is a step up at between the high and low innominate veins.
Very good. So most likely
Then
it seems that there is a pulmonary veins must be joining at the side. Okay, right. And it also seems that looking at the whole data, the pulmonary venous, the innominate vein pressure is equal to pulmonary arterial wedge pressure, indicating that the connection is from the pulmonary arterial wedge venous pressure, venous veins into the left innominate vein. So the diagnosis in this patient is
total anomalous pulmonary venous
of the supracardiac variety, where it drains into the innominate vein and then drains into the vein. Can you tell me how will you calculate the pulmonary blood flow in this patient? What is the formula?
This patient
Pulmonary oxygen saturation in this patient. Sorry, pulmonary blood flow in this patient.
Usually,
pulmonary blood flow. What is? Tell me the formula.
Usually,
Anybody or anybody? Somebody else would like to try? Navjot, would you like to try? Or Vadia, would you like to try? Vadia, I think you are very confident.
So normally the formula is oxygen consumption divided by the pulmonary arteriovenous oxygen difference.
Very good. Yes.
So here the problem is that the pulmonary venous blood is going through the going and joining the systemic veins. So I think here this thing will be low innominate veins, oxygen consumption divided by the oxygen content difference between low innominate vein and pulmonary artery. So 92 minus 88.
Why did you say 92? Why can't you make it? You should make it 100. Because see, when you are taking the low innominate vein, you are getting some of the desaturated blood coming through the
systemic vein also.
So pulmonary arterial bed, 100 minus 80.
100 minus 80.
Would you get the point?
Yes, got it.
That's the formula. See, many students do not know how to calculate the pulmonary blood flow and systemic blood flow in this situation. So, what is the systemic blood flow in this? What is the formula for systemic blood flow? Dr. Wadia?
For systemic blood flow, it will be 85 aortic saturation oxygen content will take 85 saturation will take minus the RA, so which is 88, I think.
How can you take RA?
So
high
innominate vein
plus IVC.
High innominate vein.
No, you should take high innominate vein and also take IVC also into consideration.
IVC also, yes sir.
Then you apply the same formula, mixed venous sample, and then that will give you an idea about the mixed venous oxygen saturation. So arterial about 85 minus mixed, here it will be, let us say 65 or 64, and that will be around 20. And then you apply the same formula. Could you get the point?
Yes, sir.
Could you understand?
Yes, sir. Yes, understood.
Yeah. So first you take the pulmonary arterial wedge, which is 100, minus pulmonary artery oxygen saturation 80, that is 12. On the systemic side, you take the oxygen saturation aorta 85 minus mixed venous oxygen saturation by calculating from the IVC as well as high SVI innominate vein oxygen saturation. So that will give you the correct one. Could you understand? Radhashran.
Yes,
Now, Jyot, okay, right. We will go to the next case. Is it clear? Any doubt? This is it's slightly difficult to analyze, but once you are vigilant and you can interpret the data correctly, there is no problem. Okay, we'll go to the next one. Right, okay. Any takers? It's very simple. You should volunteer immediately. Anybody would like to volunteer? Anybody can try. Ramesh, would you like to try?
Yes, sir.
You try. Okay.
14-year female, sir. RA pressure is A10 V6. Slightly mean is 6 normal, sir.
But A is slightly elevated.
A is slightly elevated than V, sir. Yes, sir.
Okay, very good. Yes.
RV pressure.
You need not compare with A with V always. A is absolutely it is elevated because normal upper limit of A is 8. Here it is 10. So there is some elevation of the
yes, sir.
A wave. Right. Okay,
yes. Then RV pressure systolic is 100, diastolic is 10. It is significantly high, sir. RV pressure systolic.
What about the?
And there is no gradient across the. Yes, sir. There is no gradient across the trachea.
Very good. Very good. Yes. Yes.
Then PA pressure is 25 by 10. So there is significant gradient from RV to PA.
Okay. Very good.
75 mmHg.
Okay.
Pulmonary artery wedge pressure mean is 7.
Pulmonary artery pressure is it normal or abnormal or what is it?
It's normal, sir. Mean is 15.
Very good. Yes. Yes.
So there is significant gradient across the from RV to PA.
Very good.
Then pulmonary artery wedge pressure is normal.
Okay, very good.
LV pressure is systolic 100, LV EDP is 7. Okay. That is normal. Aortic pressure is also normal, sir.
Okay.
There is no gradient across the aortic wall.
Okay. Is there an abnormal equalization of pressures?
There is an abnormal equalization of pressure in RV, LV and aorta, sir.
Very good. Okay. There is a abnormal equalization of systolic pressures in RV, LV, and aorta.
And aorta. Yes, sir.
Oh, very good. Okay, yes. Now,
Uh,
so we have to consider whether it could be tetralogy of Fallot. Okay, right? Yes.
Yes, sir.
Hmm.
In oximetry, SVC is 69%,
Hmm.
IVC is 72%,
Hmm.
RA is 71, RV is 73, PA is 73.
Hmm.
So there is no significant step up or step down here.
Very good.
Then pulmonary artery wedge is 100%, LV
Very
is
good.
99%, aorta is 98%. So there is no
Hmm.
significant step down also from aorta, from wedge to the aorta, sir.
Okay. So do you think that it is tetralogy of Fallot?
No, sir. It's because there is no decrease in the saturation in the LV.
Okay.
So there is less likely there is VSD.
No, not less likely. There is no VST.
Yeah, there is no VSD, sir.
Yes.
So it's most likely isolated pulmonary stenosis.
Very good. It is a pulmonary valvular, so isolated pulmonary valvular stenosis. It is only accidental that RV, LV, and aortic pressures are systolic pressures are equal.
Yes, sir.
So, even when you get pressures equal, don't jump to tetralogy of Fallot. You should look for other evidence, and the evidence is desaturation in the LV.
LV.
Here there is no desaturation step down at LV, so there is no right left hand at the ventricular
level.
So that is so we cannot diagnose tetralogy of Fallot. So this is a valvular pulmonary stenosis. Is it mild, moderate, severe?
It is severe, sir.
Severe. Very good.
Gradient is
Excellent.
75.
I think very good. Doctor, what you are doing with? What is your first name?
Sir, I am Ramesh.
Ramesh. Okay. Oh, you are Ramesh. I think Ramesh did. Okay, right. Okay, Ramesh, you did extremely well. Excellent. Okay, right. Yes. We'll go to the next one. Any doubts? Why we moved from tetralogy of Fallot to the isolated pulmonary valvular stenosis, even though there is equalization of RV, LV, and aortic systolic pressures. That you should understand. Okay, we'll go to the next one. Any takers? Anybody can try. We'll skip this. This is something which we have already seen. We'll skip it. Okay, take this. Okay, right. Yes. This is very much similar to one which we have already discussed, so that there should not be any difficulty. Anybody can do it without any difficulty. We have already done one of this nature.
Yogesh, you can try, Yogesh.
Yogesh, anybody can try. This is, we have already done one, so there should not be any difficulty for discussing this one. Anybody? Okay. So then one of you, Dr. Wadia, would you like to try?
Okay, sir, I'll try, sir.
Okay.
11-year-old female, sir. Coming to RA pressure, A is 5, V is 4, mean is 4, so it is normal.
Very good.
RV pressure is 45 systolic and 5 diastolic.
Okay.
There's no gradient. There's gradient of 1, which is not significant. PA pressure is 40 systolic, 20 diastolic. Mean is 28, mildly elevated. Coming to wedge, pulmonary wedge pressure, A
is actually it is 5. You mistake.
Okay. A is 5, V is 4, mean is 4.5.
Very
So
good. Okay.
again, that's normal.
Okay.
LA A by 5, V 4, mean is 4, normal.
Okay, very
LV
good.
110 systolic, 5 diastolic, so no gradient from LA to LV. And
Very good.
aorta systolic 110, diastolic 70, mean 85. So that is also normal with no
Okay,
gradient.
very good. Yes. So you would now tell me the abnormalities here.
So mild PAH,
Okay.
With mildly elevated RV pressure also.
Okay. And equalization of pressures between?
Equalization of pressures.
No,
sir, no.
Between LA and RA?
Between LA and RA.
Okay.
Right.
So obviously there's and also the catheters were moved from most likely it ascended LA Obviously meaning that there is a unrestricted
ASD.
ASD. Okay, right. Very good.
Large
Yes.
ASD.
Okay.
Coming to oximetry data, high SVC is 65%, low SVC is 94%. So significant step up of 29% here.
Very good.
IVC saturation is 72%. So that gives a mean of around 67%.
Okay. Very good. Very good.
Mid RA is 91%. So from low SVC to mid RA, it's almost there's a step down of 3.
Okay.
So RV is 92%, PA is 92% again. So no significant step down after that.
Okay. Very good.
Wedge saturation is 100% and LA is 91%. So step down here.
Okay.
And LV is 90%, aorta 90%. So no further step down again.
Okay. Very good. Yes.
So it's again a supracardiac TAPVC with large ASD.
Okay. Very good. It is not obstructed because the previous one there was an obstruction at the
yes
at the region where the innominate vein was joining the superior vena cava. Here there is no obstruction at any level.
Obstruction. Yes.
Very good. Excellent. I think. What is your first name, Dr. Wadia?
Harnish, sir. Harnish.
Harnish.
Yes, sir.
Okay. Very good. Excellent. I think you are very confident also. Very good. We'll go to the next one.
Hello, sir. Previous case.
Oh, okay. Right. Yes.
Why can't it be PAPVC, sir? Partial.
Why can't it be partial anomalous pulmonary venous drainage? It is very unlikely that in partial anomalous pulmonary venous drainage, you will get equalization of oxygen saturation in all these chambers because the mid RA, RV, pulmonary artery, left atrium, left ventricle, aorta, everywhere it is equal. That is not the feature of usually oxygen saturation in the LA will be much higher than that of the RA in a patient with partial anomalous pulmonary venous drainage. It will be just like ASD. You will get a step up at the RA level, but the oxygen saturation in the LA will be significantly higher than that of the RA. Here, all the chambers, RA, LA, LV, aorta, RV, everything it is equal. And also the pulmonary artery oxygen saturation is more than that of the aorta. All put together, I think you have to go for total anomalous pulmonary venous drainage. Okay, any other doubts?
No, sir. Thank you.
Okay, right. We'll go to the next one. Okay. Any takers? Anybody new? Somebody who has not yet discussed would like to discuss? You should always come forward and try to discuss. I also will help you in interpreting the data so that you gain confidence in looking at the hemodynamic data without any difficulty. If nobody is attending, we'll start with again with Dr. Navjot. Would you like to discuss? Okay.
Yes, sir.
Yes.
Sir, 1-year-old male coming to
1 year old, 31.
31, sir.
Okay, yes.
The pressure data is like A is 16, V is 18, and V is more than A. And the mean RA pressure is raised, that is 16. RV pressure systolic is 48 and end diastolic is 9. And there is a gradient between the atria and the ventricular pressures.
Very good.
And
Very good. Excellent. Very good.
Then the artery pressure systolic is 48, diastolic is 20, with mean pulmonary artery pressure of 30, slightly raised, and there is no gradient between the RV
Very
and
good.
pulmonary
Excellent.
artery.
Excellent. Very good.
Pulmonary artery wedge pressure A is 12 and V is 15 with mean of 13, almost normal.
It is slightly raised, not normal, it is raised. Because up to 11 is normal, 12 and above is abnormal. So here it is 13, so it is slightly elevated. Okay, very good. Yeah.
The LV is 140 systolic and diastolic is 12. So since we do not have LA pressures given, so there is no significant gradient between LA to
Okay,
LV.
very good. Taking-
The aortic pressures, systolic is 140 and diastolic is 60 with a mean of 88. Then there is no gradient between LV and aorta.
Very good.
So in the pressure data,
You have to interpret the aortic data also. Aortic pressure data.
so there is a pulse pressure is raised. Sir.
Oh yes, you have a wide pulse pressure, and systolic pressure is slightly on higher side, 140. But there is definitely a wide pulse pressure. You should discuss that also. Okay, very good. Yes.
And sir, now from the pressure data, what we can get is that there is raised RA pressure with a significant gradient between RA to RV. And mean pulmonary artery pressure is raised, and mean capillary wedge pressure is raised, and aorta, there is a wide pulse
Very
pressure.
good. Excellent. Okay.
Coming to the oximetry data, we have taken two samples. SVC high is 68 and low is 67, and IVC is 74. So mixed venous is around around 69.5, sir.
Take it as 69. All right. So, 67, 68. Take it as 69. Very good. Yes.
Then RA, the RA is 76.
Okay.
So we have a gradient of saturation grade about step up of about 7% if we are taking the mixed venous oxygen.
Okay,
sir.
very good. Not even 7. You can give. You can look at the RA lower. It's 83.
Yes. So RA high, low, and the 76, 83, and 82. So we have to take a mean of around 82, sir. 80.
No, you don't have to go for mean and low. You can actually pick up the highest value. Some people even say that if there is a big difference between RA, between high, low, and middle, you can even look for the oxygen saturation in the RV or even in pulmonary artery, because that is the area where you can get real good mixing of the blood, provided you are sure that there is no left to right shunt at the RV level or at the pulmonary artery. Sometimes in a patient with ASD, the real mixing of the blood may take place only in the RV, because there is a streaming of the blood towards the RV, and oxygen saturation, the slip up of the oxygen saturation may be best detected by the mixed oxygen, the real step up which is picked up in the RV without any BSD. But you should be sure that there is no BSD. That's all. Okay, so here the oxygen saturation in the RA it has gone up to 83, but in the RV it is 86. So is that enough for you to call it that there could be a VSD?
No,
No,
sir.
that's not enough. Okay.
No different, significant difference.
Okay, right. Yes.
So there is a significant difference from mixed venous to RA.
Okay, very good.
But no significant difference from RA to RV.
Okay.
So it's only, and pulmonary artery is 86, and pulmonary arterial wedge pressure is 100, and LV and aortic pressures, they are normal.
Okay, very good.
So here we have a patient who has got a significant step up at RA levels.
Very good.
And there is a the V wave in the RA pressures are also raised.
Very good. Excellent.
And we haven't got the LA pressures, but the RA mean is greater than the pulmonary. If we take the LA pressure as mean pressure as 13, then so the RA pressure is greater than the LA pressure actually.
RA pressure is greater than the pulmonary artery wedge pressure. That means more than LA pressure. Okay, very good. Yes.
Sir. And
so obviously here a shunt is coming to.
So there is a left to right shunt. Sir.
Very good. At what level?
It is at the RA level. Sir.
RA level. What are the conditions where there can be a left to right shunt at the RA level?
So one is the ASD.
Very
sir.
good.
Another
Second,
is LV to RA,
Very
that
good.
is fissure boards.
very good,
Then we can have a ruptured sinus of Valsalva to RA.
very good. These are the three situations where one shunt coming from LA, second shunt coming from LV, third is coming from the aorta. So out of these three, which one do you think is most likely? What is aortic pressure?
Raise to to RA.
Aortic pressure is 140. So,
No, there is a runoff from the.
runoff from the aorta to probably it may be ruptured sinus.
Not probably, most likely.
Yes,
So
sir.
then how will you explain the gradient across the tricuspid valve?
Sir, it is because of the flow probably.
May not be too much. You can also always think that sometimes this sinus of Valsalva sometimes can bulge partly into the tricuspid valve and may produce a
Right, sir.
tricuspid stenosis-like situation.
Right, sir.
And which sinus ruptures into right atrium?
Sir, it's a right coronary sinus.
Well,
Non-coronary sinus.
non-coronary sinus. So right coronary sinus mostly ruptures into the right ventricle.
Okay.
And of course, I agree with you that sometimes right coronary sinus also can rupture into right atrium. But when there is a rupture into right atrium, you must always think of the possibility of non-coronary sinus rupture. Very good. I think you analyzed it very well. Excellent. I think you have improved, and also great confidence. I think from the today's start till now, I feel you have become very, very confident and very excellent. Excellent. Any doubt about the interpretation? If anybody is having any doubt about interpretation, please ask. Okay, we'll go to the next case. Okay. This is much simpler. Any takers? Radhakrishnan, would you like to try, or somebody else would like to try?
Yes, sir.
Yes. Is it Radhakrishnan who is trying?
Yes, sir.
Okay. Radhakrishnan try. Okay, yes.
25-year female patient. That, RA pressure A6 and V4 normal.
Okay, very good.
Then RV pressure systolic is 50, diastolic is 6, elevated
Very good.
systolic pressure. Then pulmonary pressure is systolic 50 and diastolic is 25 and mean is
Very good.
35.
Is it normal?
Elevated.
Elevated. Is there a gradient across
Elevated.
the pulmonary valve?
There is no gradient.
Is there a
no
gradient
sir.
across the
Both
tricuspid valve?
Sir, A6 is 2 millimeter.
What gradient? Reverse gradient.
Sir, A6 no
Yeah,
gradient.
no gradient. A6
Six.
and RV and diastolic pressure is 6 or no gradient. Okay, right, yes.
No
Okay,
gradient.
yes.
Pulmonary wedge pressure A is 26, V is 25. Both are
Okay.
elevated. Then LA pressure A is 26 and V is 24.
Okay,
Elevated.
very good.
Then LV pressure systolic is 120, diastolic is 5. Normal,
Okay.
sir. But,
Now you have to mention, is there a gradient across the mitral valve?
sir, actually, yes, sir. There is a gradient
Okay.
across the mitral valve around 19 millimeters.
19 or even 20, because there is a mean
20.
left atrial pressure is 25 and LV and diastolic pressure is 5. You can easily say that there is a gradient of more equal to 20 millimeters of mercury. Okay, right. Very good. Yes.
Aortic pressure is systolic 120, diastolic 80, mean 95.
No, very good. Okay,
Normal.
yes.
There is that's a
So
gradient
interpret
blood
it now. You see from the pressure data given to you, what is your diagnosis?
Yes. mitral stenotic has the mitral
There's
valve
a gradient across the mitral valve
and
so that patient is
LV.
having severe mitral stenosis, yes.
mitral stenosis.
And also patient
And
has
elevated PA, pulmonary artery pressure.
there is a moderate pulmonary artery pressure or low moderate pulmonary artery pressure. Okay, right, yes. Then some procedure has been done.
Yes, sir. After the procedure, RA pressure is 5 V4, RV pressure systolic 42, diastolic 6.
What has
There is a
happened?
reduction.
There is a slide
reduction 8 millimeter.
Okay.
After the procedure.
Okay.
Pulmonary artery pressure systolic 40 and then diastolic is 16. There is a reduction in systolic around about 10 and diastolic about 9 millimeter.
And mean pressure also fell by about 11. Okay, very good. Yes, okay.
Yes. Then pulmonary LA pressure, A wave is 16 and V wave is 15. There is 10 millimeter reduction.
Very good.
After the procedure.
Very good. Yes.
Then LV is 110. Diastolic is 7. There is a reduction in the LV pressure, but there is a reduction in the gradient between the LA and LV.
Significant reduction in the gradient between LA and LV. Okay, very good.
LV.
Yes.
10 millimeter mercury. And aortic pressure is normal.
Right. Anything in the oximetry data? So here, after the procedure, the significant difference was that there was the gradient between LA and LV has significantly come down. So what may be the procedure?
BMA.
Balloon dilatation of
balloon mitral valvuloplasty. Okay, very good. Yes. We're looking at the oximetry data.
Yes. SVC.
Anything abnormal? You need not, because now you have seen many data. So is there anything abnormal there? No. So what is the procedure, and do you think that the procedure is successful? What is the criteria to say the procedure is successful?
Sir, there is that 50% reduction in the mean gradient.
Yeah, there's a 50% reduction in the gradient indicate that it is a successful procedure. So here, what was the gradient reduction?
50%.
50%. So this is a successful procedure. So the patient has undergone a balloon mitral valvuloplasty, a successful balloon mitral valvuloplasty. Did the patient develop a complication? Has the patient developed a MR?
No.
Why?
Sir, V wave. There is same reduction, sir. No increase in
V wave significantly come down. Actually, from 25 it has fallen to 15. So there is no hemodynamic evidence to suspect that patient has developed mitral
regurgitation.
Okay. Do you want one more case? I think that can be the. Okay. Any doubts about this case? So we'll have the last one. Okay. This is the next one. Is the last one. Okay. Right. Any volunteers? Any volunteers? Okay, I will end with Ramesh. Would you like to try? Ramesh, are you there?
Yes, sir. Hello. It's a 12-year-old female. In pressure data, RA pressure is normal.
Okay,
sir.
very good.
RV systolic pressure is high, 45.
Very good, excellent.
PA pressure is 30/12. Mean is 20. So it's borderline.
Okay.
But there is systolic gradient of 15 millimeter of mercury from RV to
Okay,
PA.
very good.
Pulmonary artery wedge pressure is normal, sir.
Okay.
So there is mild valvular PS, maybe from this data we can see.
No, don't interpret as mild valvular PS. You see that there is a mild gradient across the
pulmonary wall.
pulmonary valve.
Yes, sir.
You have to, you should interpret it
Yes,
only
sir.
after having seen the whole
Yes, sir.
data.
So
And is there any abnormal localization? Not much.
no,
Okay,
sir.
right. Okay, yes.
In oximetry, SVC 66, low SVC 68, IVC 71, high RA is 78. So there is significant step up at the RA level. Mid RA is 84 and low RA is 86. RV is 90%. So there is significant step up from SVC to RA level.
Very good. Yes.
And left-sided pressure, oxygen saturation are normal.
Okay, very good. Yes. So what do you think is the problem?
So there is the left to right shunt at the level of RA, sir.
Okay.
With mild pressure gradient from RV to RA, most likely it's because of the ASD with flow related.
It must be most likely this minor 15 millimeters of mercury pressure gradient across the pulmonary valve must be related to
because of the ASD
torrential flow.
Yes, sir.
Flow. Okay. Okay. I think it's 9 o'clock now. Any doubts about we have got few more cases, but I think we'll stop at this level. Any doubts about the hemodynamic data? Okay, I think most of you discussed very well. I think, and also towards the end, the confidence level has gone up like anything. I think it was very good discussion. Most of you did extremely well. I think more and more people should take part in the discussion. Then only you can gain confidence so that in the examination you can perform very well.
Yes.
So next Friday, any doubt? Yes.
No, sir.
Next Friday, what would you like to have? Is it you would want to have clinical discussion or you want to have something something different? You want to have X-ray discussion or angio discussion, or we'll have a clinical discussion, one more case. All right?
Okay.
Is it all right to have a clinical discussion in the I will bring a case, but if anyone of you is having a good case, bring that case so that we can discuss that everybody can understand how to discuss a case properly. So if you have any case, you can also bring the case and the case can be discussed, and that will make the discussion more lively. Anyhow, I will be bringing one case, and if nobody is bringing a case, we'll have a discussion. We'll have a clinical discussion next Friday. Okay. Any doubts about things which I have told you today? You can ask now.
No, sir.
No, okay. I think that's fine. I think then we'll stop at that level. Okay. Okay. Good night.
Good night, sir. Thank you, sir.
Thank you,
Thank you, sir.
Thank you, sir.
I think all of you did very well. I think you could gain a lot of confidence and look at the data more correctly. And I think I'm quite pleased that you did it very well. Most of you did extremely well.
Thank you very much, sir.
Okay, fine, great.
Thank you, sir. Good night, sir.
Good night.
Thank you, sir. Good night.
Good night. Okay, is okay, all right. We'll stop at this level.